Tina, we noted you are the only hospice in New Zealand providing assisted dying, so that might be a bit of a lonely place. How do you manage your interactions with other New Zealand hospices, palliative care services, palliative care professionals?
Absolutely professionally, the same way that we always have done. You know, I think there's a thing about you have to just respect that there's different views. You've got to be able to use the data. You've got to be able to keep a stable mood and way of interacting and not bite. You know, sometimes it can be a sector that wants you to bite, and you just have to have the confidence in your own position that you're doing that around your values based on patient choice, and almost politely dare them to have a major issue with it. I know that sounds terrible, but that's the truth. And what we found over time, you know, 3 years on, the sky hasn't fallen in. And, you know, I'm lucky to work with some really fabulous people. Because we disagree on one issue does not your whole professional network destroy. And you hold those relationships, and over time, we now have, there's 28 funded hospices in New Zealand. That's a lot for a small country. But we now have 2 or 3 of colleagues and partner hospices beginning to ask and explore. And I think that's because the public has stayed very staunch, but also whether they've told us or not, they have been watching, and nothing terrible's happened.
Brendan, anything to add from Irish healthcare professionals' perspective?
Other than we're kind of light years behind what you're doing, and I think I would hope that, you know, if we're getting together in 10 years' time, that we will all have moved on.
Yeah.
That this is the process of managing change around a really difficult, important issue, and the change people say that there are 3 phases you go through: utter scorn, frank rejection, followed by axiomatic acceptance. And you're leading out of that. And
I think what was the most important thing was I feel that I have a duty of care to the clinicians who work for Totara, what clinicians and not clinicians, but to make sure that every opportunity was given to them as a good employer to be supported in who they were and being courageous enough to provide those services in a new way, and to make sure that we could link them. And our colleagues in Australia, particularly through Vadans, has been very much that professional family, and you have to make sure that you do actively seek and nurture those connections.
Well, on that, Tina, one question from another table was around the attitudes of your staff, including conscientious objection. How do you handle or manage that?
Actually, it's been okay. The first thing about conscientious objection is that you absolutely respect an individual's right to have it. Right? This isn't about trying to suppress different belief systems. It's about providing absolute clarity about what the expectations of the law are around conscientious objection, and making those really clear, providing education about how conscientious objection works, and making that a safe process for people. So at Totara, we expect everyone to meet the requirements of the law. We provide that training. We have a conscientious objection register which is open, and I can tell you today there's only 2 clinicians that are on that register. And many others sit back just feeling curious, and over the years many others go forward and look for preceptorship on the issue. So transparency and fairness at every point, I think, is your friend. Okay.
On the more corporate end, then, one of these questions is about, was there any effect on funding? And tied into another question, our hospice, I suppose that fundamental reputational risk of the hospice as being a place of death. Was there any impact on either your reputation, and your reputation is what very often drives the fundraising, and your 50% funding, any impact on that?
You're going to love this answer. Our funding went up because the community members donated more and more to us in belief of the choice, and we became much more widely known in New Zealand, which was really good. We received hundreds, and we still to this day, it's such a privilege, we receive hundreds and hundreds of texts, emails, phone calls, letters, thanking us for taking the position that the New Zealand public had taken for granted that palliative care would do this work, right? Because we've purported to be the experts for all the time, and I can count in 3 years, this is how many letters we've had. 3 of them have been from right-wing religious organisations, 1 from a palliative care leader in ANSPAM, and 1 from a member of the public, but that's against hundreds. I often get asked, but what would you do if, what if someone says to you, we're going to withdraw your funding based on that? And I'm a bit like, well, do you take clean dollars or dirty dollars, right? Because if someone said to you, well, if you're going to keep treating all those gays, we're going to remove your funding. If you're going to have those bespoke programs for Muslims, we're going to remove your funding. If you're looking at having Indigenous programs for Māori, we don't want that. You just say, haere rā, bye, right? So I'm not interested in your dirty dollars. We have integrity, but luckily we haven't been able to do that. And I just want to say that one of the reasons I think it's been a process and a system with great clarity to work in. And I know she can't speak today, but Dr. Kristen Good is here from New Zealand who heads the whole ministry team as the Registrar for Assisted Dying. And Kristen's work with her team made implementation and training and being able to respond something that just had absolute clarity. So thank you, Kristen.
We'll just get the mic over to you, Christine, if you don't mind, just so everyone can hear. Thanks, Brendan. Brendan is the agile on his feet. He's the young lad of the afternoon.
I've been in training.
I just really wanted to make it clear that for people in New Zealand, access to a place to receive assisted dying is not always easy. And one of the most critical things that Tina and her team have provided is a place for people to be able to access a legal health service within New Zealand where there were barriers everywhere else. And people travelled from across the country to access that care that only Tina was offering. I just wanted to acknowledge that because she's been very humble when she's done such amazing things.
I'm going to ask a question because you mentioned it the other night in the conversation. Is the reality in the other hospices is that people are trolleyed out if they request assisted dying?
Pretty much, yes.
Yeah.
So there's many aged care facilities in New Zealand, and there's almost all of the hospices will trolley their patients out or refuse care, but also we know that sometimes even just tenancy, if you happen to be rental accommodation is very high in New Zealand. We have a housing market that thinks it's Manhattan, and so housing is huge, and people have been turned away because their landlord won't have them have an assisted death at home. So we call those patients forced transfers. Half of the patients that we accept are forced transfers. So they come to us because they've managed to get our telephone number, our website, we promote it widely. They have a family member or their own self who have got in contact. Dr. James Yap is the clinical medical director, Georgina Haley, our team, and we make sure that those people can come to us, that they can be within our wards or within our wider family accommodation, and that they're treated with dignity for their choice and can be with us for 48 hours before if they've been transferred through for someone else, because you want someone to actually be in a good, peaceful state, right? But it's a great harm in New Zealand, and it was a great harm that was unfortunately triggered by the actions of Hospice New Zealand, who took a high court case in New Zealand and got the right to organisational level conscientious objection, allowing facilities at an organisational level to reject those patients. I don't think that Justice Mallon in her finding intended harm, but harm was most definitely caused, and we don't feel, don't get me wrong, we're not like, oh, we are heroes. We simply feel that those are the patients that we've committed our professional lives to, and it's not right to have someone be carted out and be told to have their assisted death in a car park. So they are welcome at Totara.
And it struck me as such a compassionate service. I think we've answered the question. There was no problems with public funding, so that's an important message to take back to employers. On the notion of palliative care professionals, we have a couple of questions here, but the one I'm going to pick out is, how did you get the more secular palliative care professionals to stand up and speak out? Or have you any ideas how that might be done?
By secular, you mean those not wedded to the traditional?
Yes, yeah.
I wish Dr. James Yap was here. He's our medical director and he's a great pal of mine, colleague. It was about doing that work, you know, putting those values up, putting up our vision, and actually getting really sensible professional people in the room to really look at what their practice meant in line with those values. And to be brave enough, if James was here, James would tell you openly that he voted no in the referendum. And after he did the work, he openly came out and said, I might have voted no at my kitchen table, but in my job, it's not about me. And it's about what is the care that my patients need. And that begins to build a community of trust and dialogue. So James, then we get a nurse practitioner, and then we get a junior doctor, and then you have a registrar, and then and all of a sudden you build a community of dialogue. And as leaders, our job is to keep that community of dialogue nurtured and connected.
Do you ever have any, I think this is a question or a concern, do you ever have families that are fighting with each other about assisted dying and coming into the hospice? Does that happen?
It really hasn't been a huge experience for us. What I would say is, wherever there's trauma, you know, you go into an ICU, you go into a general medical ward, I think when people are junior clinicians or whatever, they always expect that bad behaviour will be managed and people will behave. People don't behave well with trauma. Behaviour gets worse, right, until it gets better. But really what's happened for us in our experience, people love the person who's dying. And human love and compassion is an extremely strong overriding thing. And even so, if they've got some concerns about it, they can it. Because actually they realise it's the choice of the person that they love. And they'll support that choice on the whole. We have had some patients who've said, you know, my sister just can't cope with the fact I'm doing it. So I've said to my sister, it's fine, you don't have to come. You know, and it's that person being able to stand on their own authority, that it's their choice. What I would say to palliative care and to general practice and to hospitals is, that's actually no different from what we deal with in the health system every single day around a multitude of healthcare issues. Right? And I think that we keep trying to make concern or anxiety tries to make the human condition somehow be very different in this context, and it's not.
Okay, Tina, a question here in specific to New Zealand. How did the Maori population respond to assisted dying?
Well, in our experience, and there's been others who've done, so Jess has done some research, and Kristen's team, and also Dr. Tess Moeki Maxwell, Maori woman who's a fantastic researcher. But there was, I think, a uninformed view that Maori would not avail themselves of assisted dying. You know, people have stereotypes about populations. In Totara, we have one of the largest Maori communities in the whole of New Zealand, outside two other areas. So although Maori are 12.5% of all deaths in the country, about 4% of Maori have used that service. And we also have to remember that Maori are a very young population comparatively when you look at socio-demographically. So I would answer in a way that's entirely led by them in their way, using their own cultural norms and values, and in a way that I think the mainstream didn't expect.
Okay. This question comes back to, our understanding was palliative care were involved in the writing of the legislation, how it would work. There's a question here, do you think the New Zealand law would be broader, more flexible if palliative care had not been involved in its formation?
I think that the New Zealand law would have been broader if we didn't have an MMP system, multi-member parliament system, where politicians were continually horse trading. And some of that was influenced by palliative care, and some of that was influenced by religious groups, but it's also fair to say that the pro side was also influenced, right? And it came down to what was the appetite of the politicians. And, you know, I don't know if Mike Gaffney's still there, but I wish we had an awful lot more like you, Mike, wherever you are. There you are, my friend. Because the horse trading and the trading off became about process in somewhere, in my view. It's just my view. The actual people that we were setting this law for got lost. The other side is that someone said earlier today, 80% of something is better than 100% of nothing.
Yeah, and the reality is that all major stakeholders will have to be involved in some way in the creation of the legislation, so that, you know, it's inevitable you'd want to prepare for their...
Yeah,
and on that note, Ireland has a new national palliative care policy that was only launched about 2 weeks ago. So in some ways, that earlier, I think Greg was talking about that concern that there wouldn't be funding towards palliative care. That question should have been answered in an Irish context this stage, because there's a new national policy after 20-something years in place now, where they've committed to equitable palliative care all over the country, either in acute hospitals or in facility.
Yeah, there's one thing that I would hold palliative care accountable for, and I feel like I can say it because it's like you can talk about your own family, right? No one else can. But I really think that there's an ethical obligation to look at the facts, and particularly as healthcare professionals, to not in quite a mischievous way and quite a harmful way use disinformation and use feelings as if they were facts. And my criticism and my challenge to palliative care colleagues is, let's have a dialogue and let's do that respectfully, but let's do that around the facts. And I want you to commit to not using disinformation and to engage in information, because we will walk with you on that respectfully.
Which is a lovely answer. One of the, I suppose, unintended consequences could be, and somebody's put it down here saying, because many hospices have long wait lists, I'm not sure, I don't think they have very long wait lists here. Could VAD be seen as a way to move people through more quickly to increase vacancy? Free beds up, is there a potential of that?
There is no waiting list for hospice care in New Zealand.
Yeah. And one of the key performance indicators in Ireland is that there's a very short wait list that people are seeing within 7 days or something like that. Brendan, do you have any comments on that from access to you as a family practitioner? Any wait lists for?
Well, I mean, what we understand about it in Ireland is that we're actually fairly well provided in terms of palliative care, but not uniformly so. We know that there are geographical black spots. And we also know that the way care is provided does vary from one area to the next, depending on the demography, depending on whether there are adequate numbers of GPs or not, whether it's rural or urban. So that makes it difficult to kind of make sweeping statements that we will do it this way or that way. So yes, we do have a new policy, and we all rolled up to our sleeves to generate that policy, but we hope that it will have adequate complex adaptivity, that it will be able to take account of the regional variations. It's 2 weeks old. We've read it with a magnifying glass. Nowhere is assisted dying mentioned in it at all, whatsoever, at all, which on one hand isn't surprising, but on the other hand, of course, is quite surprising. But anyway.
Yeah, anyway. In relation to your own internal stakeholders, does the opinion of the hospice volunteer matter, or were volunteers' opinion considered in New Zealand? And somebody said this happens in the Netherlands.
Yeah, of course the opinion of volunteers matters, but also volunteers similar to employees, same but different, right? If you cannot follow or do not want to follow the values of your organisation, don't volunteer for it, right? If you don't want to work in palliative care, don't apply to a hospice. If blood makes you feel sick and you don't like broken bones, don't be an emergency care physician, right? So we're very, very clear We put our position on all of our literature, our volunteer applications, our website, our job descriptions, our website, our interview process, to make sure that, that people know what our position is. And they don't have to believe that same thing, you know, uniformly. They just have to respect that thing.
This question is coming back to religiosity again, and I suppose to echo that the earlier origins of many of the hospice movement. As our hospice is religious-led, will it ever be provided? Do we have to have a new facility? I'm not sure whether you can answer that. But
well, I think that's totally in your own hands. Like, Totara Hospice was founded by an Anglican priest. His name was Father Francis Fennell, and his wife Beatrice. And I know this story because many of our founders, our founding members, are in their 90s and still alive and kicking and part of my Masters Guild of volunteers. So it's lovely to know the history. But so when they asked him, how are we going to do this? And, you know, how do we get out into community? Father Fennell said, we're not going to make this a church thing. We're going to make this a community thing. And I think there was a man with vision around that. But we have one of our colleagues, her name is Georgina Miller. She's an allied health clinician by background. She is one of the most senior managers on our executive team. She is a devout Christian, and she is a completely faith-based ally, and she is fundamental to our service working. So I think what I'm trying to say is to put people with a range of spiritual views together and to let them challenge and guide each other through that. It does no harm.
Okay, we've got another 25 minutes for questions and comments. So we've taken lots of questions there. Who's got other questions to add into the mix? And I might just, while we're doing that, if you've got other comments or questions, you might stick up your hand and Brendan will come over to you. He's our nimble elf today. Yes, there's one down here, Brendan, here, the gentleman with the yellow tie, just at the table down there. I have one question, Justin. I might put this to yourself. It's a question. I had to look in the box with the questions there, and there was a question. In Ireland, is it legal to suggest VSED? Would a family not be held accountable to support this if their loved one is under care? Does it count as neglect? And can healthcare assistants, doulas, assist the client or family thrash this out? What do you think? You might come up here because the mic's up here, Justin. Sorry.
VSED, VSED, stands for voluntarily
stopping
eating and drinking. Now we have a system now. I mentioned it before about our directives. Up until April of last year, we didn't have a system for advanced directives. We do now. It's enshrined in legislation, and it's enforceable. We don't have a system of registration, but it does allow us to refuse treatment. You can refuse to be resuscitated. You can refuse to be artificially fed. You can refuse mechanical ventilation. You can list them all there, and the more that's listed, obviously, the easier it is to enforce these directives. But then when it comes to choosing to refuse eating and drinking, then that's a choice of your own, and there's no law against it. They used to apply it for hunger strikers. If you remember, they used to force hunger strikers, but that then was made an issue, and it's no longer legal to stop them.
Okay, thank you, Justin, for that. We've just one observation here is in relation to the questions, any concerns or anything, and the comment was the customer should get what he wants, but often the patient is not the customer, it's the government, and that's a thing. I suppose it's a complex mix of stakeholders. Do I have another hand up down here? I'm going to ask a really practical question, Tina. I'm really curious about how it works in practice. So if I was to come into the hospice with a terminal diagnosis and I was considering assisted dying, how would that conversation be facilitated? How would my care, what would happen? Just walk me through that in a really practical sense.
So I think that Gary and others have talked about the gag clause. So the first thing is that the patient needs to raise the issue with the clinician. So if we just take for granted that that's occurred, then what happens is that the physician, the person is told about support and consultation end of life New Zealand. that triggers the appointment of an independent medical practitioner and the person's own attending medical practitioner. If the attending medical practitioner has a conscientious objection, then a second independent medical practitioner will be appointed. Those medical practitioners then assess the person for competency, capacity, coercion, that they meet the eligibility within the Act. If the person is found to meet that, then the application then goes through to Kristen's team for that to be checked. And when everything is approved, it then comes back to the patient to choose the time, manner, location, method of the death that they want to have. And they've got generally up to 6 months to do that. And that can be extended. If it's extended more than once, then you need to go back for start the process again in terms of capacity. But if you've chosen your time, date, and method, so say it's 4 months on, and then you want to be at home, then the clinician will be with you at home. Your medications are administered 48 hours before, and you have chosen whether you want to ingest those yourself, push your own IV line, or have the clinician do it for you. And once you've made that choice, then it goes through still with a final consent in New Zealand. But that is the process. Okay. And most of that takes about 21 days on average, although there's a range.
So 21 days will be, so somebody who's imminently dying wouldn't have time to...
It's got better, but depending on where you are, urban, rural, etc., around that, so there can be a range, but it's beginning to get sharper.
Okay, okay. Do I think we have a question here, have we?
I'm not sure it's a question, but considering the things. My name's Pascal Landa. I'm the president of Vivre in France, and I've been in this movement since the 1980s. So I have thought a lot about the subject that you've been hearing about for the last 2 days, and I'm a troublemaker. I'm a troublemaker because I have come, after 20 years of reflection on this subject, to come to the conviction that we are asking for law on medical-assisted dying, and that what we should be asking for is a law that nobody can object to. And when I say nobody can object to, the objections that are made to us and that are throwing wrenches in the works for us getting not only a law that works, but also having practitioners go with us, is that we're addressing the problem, in my opinion, somewhat from the wrong angle. What I'm saying is people who want to have assisted dying have a medical act which is no different than the medical act of taking out a leg or taking out something in your body that is going to change fundamentally your life. And that the protocol for doing those things ought to be the same as assisted dying. We need to have a good diagnostic, we need to have confirmation of the diagnostic, we need to have confirmation that the person understands what's going to happen to them, we need to have the doctors document everything on the way so that we can, after the fact, eventually control what happened. There's no abuse, the slippery slope, and we need to have social accompaniment of the act. And if you look at all those medical acts that I call irreversible medical acts, they all need the same protocol. And so if they need the same protocol, we should have a law about irremediable medical acts that then does two very important things. One of all is it includes medical assisted dying in a normal standard practice of medicine from all kinds of medical acts. Second of all, it saves the doctors and the medical profession from all of those attacks that are made after the fact on them, because if they followed the protocol, they can no longer be attacked in justice. And we know that malpractice insurance is costing billions today in the world. So I think we need to put the doctors on our side by, in fact, including medical assisted dying. And if we do that into the Medical Act, And if we do that, then the religious lobbies and the financial lobbies, who are our main opponents, will not have any ground to stand on to advance.
Okay.
So that's all.
Thank you very much for that.
Thank you.
Okay, guys, I think we've thoroughly put Tina through her paces. I think she's been absolutely fantastic. I think she deserves a round of applause.